I just wanted to say thank you for attending the HIV and COVID talks. We really appreciate your participation, and we're really looking forward to learning a little bit more about you and the work that you've been doing. And if it's okay, we'd love to get started.
That's great. Thank you, Kelly.
Yeah, absolutely. In your own words, could you describe what your area of expertise is and what's brought you to these talks?
So I'll start by just saying a bit about the Economist Intelligence Unit where I work. So we work on a wide variety of projects in lots of different areas of health policy and using lots of different methodologies. So I should say up front that I'm not an expert in HIV, unlike many of my fellow panelists. So I work as an associate in the health policy team, meaning that I design, execute and manage projects across a wide range of topics. And a lot of our policy work is focused really on trying to find actionable solutions. So not just saying what the problem is and that it would be nice to do something about it, but trying to delve a little deeper into what that something that we can do is. So my route into working in health policy is a slightly unusual one. So I started out as an information specialist working in the UK National Health Service and universities. And then I started working for a company called Vaughan, which later became part of the Economist Intelligence Unit. And as an information specialist, I mainly worked on searching databases, sifting through the results, and critically appraising the studies that we retrieved. But I was always keen to stretch the limits of my role and try out new things. And over time, I got more opportunities to work on the analysis part of our projects. And now my role still includes getting involved with the research itself, but it's more about designing projects and leading a team of very talented analysts. So in terms of my sort of areas of expertise, I've worked a lot in emergency preparedness with the European Centre for Disease Prevention and Control. And these projects looked at various different aspects of emergency preparedness, including how to involve communities in emergency preparedness and best practices for after action reviews. And I've also been working on a few COVID-specific projects with the Robert Koch Institute in Germany and other projects on lessons learned from COVID-19. But obviously, as with most people working in any research currently, everything I've been working on for the last 18 months or so is tinged with COVID.
That makes a lot of sense. It sounds like a really interesting blend of backgrounds that you bring to the table. And what I'm hearing is that it allows you to bring an interesting perspective or a fresh way of looking at things that makes you a bit of an asset to teams that you work with in the health sector space. You can see how things weave together in a different way than perhaps somebody who's only had a more linear track in their career, where they have really different interesting and important perspectives, but one that's quite different than the one that you bring to the table. And I'm curious how you've taken that interesting blend of skills and now you've moved them into this health space. And I understand that you've recently engaged in a collaboration with VIVE Healthcare as well. And I'm curious how you guys connected, how you found that your areas of expertise and specialties combined. What did you decide to work on together? And how did that interplay with the space of COVID?
So VIVE approached us at the Economist Intelligence Unit because they were interested in looking at disparities in HIV, specifically through the lens of COVID-19. Just a bit of background about VIVE, their work is focused on innovation in HIV treatment, prevention and research, but they're particularly interested in ensuring that no one with HIV is, in their words, left behind. So they also run a lot of programs around widening access. And so this explains their interest in health disparities. So after they initially approached us, we were thinking about how we could focus this research, not just on disparities in HIV and the COVID angle, but we felt quite early on that the case for action in this particular area was actually going to be stronger if we looked at other areas to see where the themes overlapped and where there was intersectionality between different health areas, between different types of disparities, etc. And we did some initial research to look at different areas that we could look into. And in the end, we landed on including mental health in addition to HIV and other STDs and COVID. So we chose these areas really because of the severe impact that the pandemic has had on services, R&D, treatment access, everything in these health areas, but also because there were clear, measurable consequences of disparities in these areas that predate the pandemic. So what COVID has done is highlighted where these disparities exist, but it didn't create them. And just to say as well that this project is going live in ID Week, which is the 29th of September to the 3rd of October. So your participants and people watching this interview will have a little bit of a wait, but not too long before they can delve into the report and the videos and the case studies and really get to see the exciting research that we've been doing.
Well, I think in this conversation today, what we can say is we can offer a little bit of a sneak peek of what's coming down the road, and for folks to know that it's going to be coming and be on the lookout for it, because it sounds like it's a really interesting project that's very relevant to the times, and really works from the strengths of VIVE Healthcare and allows you. Now, I am curious about your space from working from The Economist, how they approached you as a member of the Economist Intelligence Unit as opposed to other partners. Like, what about that unique partnership really brings strength to this kind of activity?
Yeah, so one of the unique aspects of the Economist Intelligence Unit is that we combine the sort of the rigor and the analysis of a think tank. We've got a great track record in things like forecasting, policy analysis, and specifically within healthcare. But we also have this side of us that is a media business. So we combine that sort of intellectual and research rigor with the ability to get our work out into the public domain, to have reach and sort of impact with journalists, with journals. So we get published in peer review journals a lot and things like that. But we also get on, the front pages of BBC News and things like that. So what we managed to combine is that thing of sort of the underlying research is great and, rigorous and very impactful and interesting, etc. But then we can also reach different parts of the media and influencers and things like that to get our research sort of widely out in the public. And we also have the benefit of this great brand of The Economist, which is so well respected, and people know that what you're getting here is an independent piece of work. So although VIVE has sponsored the project financially, we have editorial control. So all of the research we've done is independently led by our team. And that also holds a lot of sway here as well. And using that brand as well, we're also able to get really interesting people to talk to. So, we did some interviews as part of this project, and we talked to some really fascinating people. And that's another advantage of the brand is, people love to be interviewed by us.
Yeah, that sounds great. I appreciate you sharing that. Part of the reason I wanted to understand more is that because we don't always see those kinds of collaborations, understanding, the strengths and value and additional benefits that you bring to those kinds of partnerships, I think is a really interesting point to bring up in these conversations of how to address sort of current events in the health sector in a way that you can get the word out quickly to a very broad audience that then can leverage those findings in those actionable ways that you spoke to. So that was really, really helpful for me, and I appreciate that. I'm curious if you could share with me a little bit more about how you addressed the issues of health disparity at the intersection of HIV, STIs, mental health, and then along with the COVID pandemic. How did you do that in the project that you collaborated on together?
Yeah, so we began in quite a conventional way, how we often start our research is with the literature review, because that helps us to understand the key kind of underlying factors, get a sense of what's happening currently. So the literature review here, we really wanted to understand what the key drivers of disparities were And also we use that literature review to help us to identify the areas of focus, because we came into this sort of quite agnostic as to which health areas we might want to look at. And once we'd done that literature review, that gave us a sort of a grounding. And then we were able to go out and do, as I mentioned, some really, really fascinating interviews with experts. And we often take this approach because we like the way of sort of looking at the literature. So building on what other people have already done, not reinventing the wheel, but, you know, looking at what the experts have already said, but then going to people who are working in the field and saying, you know, give us a better understanding of what's really happening. So give us the holistic view of what's happening here. And, you know, what can we do to try to address disparities? What are you doing currently? Where could we innovate? Where could we change, etc.? And so that's a really nice approach that we use in a lot of our research. But something that we did here that was a bit different was we used a technique called a foresight analysis, where basically we put together some scenarios for eliminating disparities in each of our focus areas by 2040. And what we did in doing this was actually to ground this approach in a stakeholder analysis as well, because I've already mentioned about how we like very sort of action-oriented and actionable research. And so by doing this, we wanted to make sure that our research was as actionable as possible. So we actually organised our sort of key findings by stakeholders, and then defining what they need to do individually and collectively for a more equitable future, as we laid out in our foresight approach. So we really wanted to sort of not just say, you know, disparities are awful, we should do something about it, but really say, this is what we can do now to help to get to a better 2040, and really sort of lay out some of those key steps so that there's some accountability for stakeholders and there's a bit of a roadmap as well. Because the problem with disparities is sometimes they can feel too big and too intractable and too intersectional. So people don't know where to start. So that's why we really wanted to sort of take that stakeholder-led approach of sort of saying, this is our big vision of what we think we could get to, but this is how each of you can individually and collectively help us to get there.
And that's really interesting. And I'm going to kind of reflect that back to you to make sure I got the full concept correctly. So I'm hearing from you is that the foresight analysis really gave you your umbrella or your big picture approach of what are the things that we took away from these conversations with really interesting people who are working at the intersection of these spaces. And it gave you more that broad view, but then by segmenting it by specific stakeholder needs, kind of looking and segmenting out and doing additional analysis at sort of a lower level, you were able to get to what are the specific needs for stakeholder A versus stakeholder B versus stakeholder C. And then from that drive these sort of differential recommendations and insights for what to do. Did I really understand that correctly, or would you describe it differently?
You understood that perfectly, Kelly. Thank you.
Okay, thank you. I really appreciate that. We had a chance to confirm that. I always like to make sure I'm understanding these really new and interesting approaches that we take in the work that we do, right? And I'm curious, like after kind of thinking through those steps and like how you got to those actionable insights, what were some of the really interesting or key insights that you guys took away from your work together that you are going to be recommending to different stakeholder groups as really interesting, important, actionable, and likely to be effective ways to address health disparities at the intersection of COVID, HIV, STIs, and mental health? I mean, that's a lot of different spaces.
Yeah, well, one of the key points was that this intersectionality. So disparities, you know, weren't caused by COVID-19, but COVID-19 showed how bad they are in a lot of societies. And disparities are very impactful within HIV, but they're not an HIV problem in the same way that disparities are very prevalent in mental health, but they're not a mental health problem. Disparities in health are a societal problem. And I think one of the things that we found really important was making that case for action and actually pulling out wherever we could some quantifiable evidence of what the impact is, to just say, yes, there's a moral case. Of course, there's a moral case for doing this. But there's a financial and economic case at an individual and societal level. But I think one of the things that surprised me in terms of one of the themes that came out and surprised all of us was really, without sounding too pessimistic, the lack of action by a lot of key stakeholder groups. So in our literature review, we found loads of reports detailing the negative impacts of disparities, and particularly in the areas we looked at, which is why we looked at them. But what we found less of was evidence of those reports and the suggested actions within them turning into concrete action. Mm-hmm. And so bearing that in mind, that was why we tried to develop the report with this goal of having a new action-oriented approach that sort of looks at where we are now, a vision for a more equitable future, and then specifies those key steps to get there. So I think that was something that was really important for us, was we wanted to try to give, as I said before, that roadmap. So, how do we get there? Not just saying, wouldn't it be great to get to health equity? And as I mentioned earlier, often disparities are talked about as this sort of intractable issues. There's no idea of where to start. Their intersectionality is the impetus for action, but can also be the reason that we don't know where to start, because it's like, well, is it a housing issue? Is it an income issue? Is it a racial issue? There's so many different things that are going on. And so it can be really hard for people to sort of unpick where we can start. And so there's an element to which it's very easy to sort of say, this is too big. How can we possibly address this? So that's why we really tried to give that impetus for action by, as I mentioned earlier, really pulling out those quantitative figures that show the impact of disparities on individuals and societies, but also trying to define that direction of action by specifying who needs to do what. And to us, that feels new and useful, and hopefully we want it to prove impactful for people as well.
So that makes a lot of sense to me. That, and I was going to come back to your point about it feeling intractable. That in many ways it's transdisciplinary, right? You're coming from multiple areas that's coming together. It makes it more of you can address it from each little space, but that's not necessarily going to address the bigger issue of the whole intersection. And then to address the whole intersection feels very big, and it's got a lot of complexity to it. And thinking through, is there a middle ground somewhere between doing something that's effective only in a small space, but not in the bigger whole, versus looking at the big problem and going, that's too big, I can't do it all by myself, and leaving it as a recommendation for someone else. And it sounds like your approach was, how can we drive that middle space and say, we do understand this is a big problem. We do understand that we need to have some intersections between the different stakeholders to make things happen. Let me share with you what we found in the stakeholder space, and then places where almost, if you would say, that Venn diagram overlaps for different stakeholders, spaces that they can come together and address pieces of the problem. Is that a good understanding of the approach that you guys are taking in driving those recommendations?
Yeah, definitely. As I said earlier, it's not an HIV problem. It's not a mental health problem. It's not a COVID problem. Health disparities transcend all of that. It's just they manifest themselves slightly differently, or they have slightly different impacts in different areas. So it's definitely something where a solution that focuses only on disparities in HIV can, by its very nature, only impact on disparities in HIV, no matter how successful it is, because it still has that slightly too narrow aim. So that's why, although we have called out where action has been taken, because we don't want to pretend that we're the first people to try to take action on this, we have highlighted where there have been great projects working in this space. And we have talked about specific things within mental health, HIV, STIs, etc., where we could take action. But as you said, we have also taken that sort of slightly zoomed out approach of thinking also about what we need to do at a health system level that will help us to get to that future of a sort of equitable health service.
If you could share, and I don't know if you can share it with us, but if you can share it with us before everything comes out at the end of September, ooh, can we get some excitement here? Are there any, maybe even 2 or 3 key insights or things that really stood out for you in that work that you would share with us as examples of the types of recommendations that you provided in your team?
Yeah, happy to give a little sneak peek to the audience. So the 2 key things that we really found as sort of takeaways, next steps, etc., were around the role of incentives and stakeholders in addressing health disparities. So one of the key things that we found was that stakeholders from institutions right down to individual healthcare providers are incentivized in the main to keep the status quo. So that's a key area for action, because you have to incentivize the behavior that you want to see. You can't sort of have a directive for do X, Y, and Z. And then if an individual healthcare provider is positively, disincentivized from doing that financially, or, in terms of the amount of paperwork they have to do, etc., then they're potentially not going to get on board with that innovation, no matter how much they might be otherwise keen to in lots of other ways. So for us, it really meant that we wanted to see, in a big picture sense, targets and standards that are actually equity based. So really putting equity at the heart of the strategy and the policy for institutions and health systems. And if you have those incentives in place, then you can hold individuals and institutions, etc., to account for delivering on them. And you're far more likely to see some success and some impact in that. And that's why we've detailed the specific actions for each stakeholders that can move towards this sort of equity oriented approach. So, some ideas we've had that we've suggested are things like thinking about the R&D landscape and how the populations that we include in clinical trials often do not reflect the whole population. So, how can we generate insights, and how can we expect individual healthcare providers and guideline producers to follow evidence-based medicine if there are sort of vast portions of the population for which there actually isn't any specific evidence on how or why a treatment works for them? So that's one of the things we've said, is that that's a really important step, is generating that research through more inclusive R&D, which is, in communities and convenient for people to take part in, etc. And also, again, thinking about this sort of equity-centered approach, funding criteria. When health systems or providers are looking at research, allocating funds to research programs or other kinds of on-the-ground programs, and they're evaluating them for funding, or they're evaluating them after implementation, equity's got to be featured in there as something that they're looking at as part of that. So those are a couple of the ideas that we've put forward in our report. And then the other part of it is the stakeholders. And here it's not about just thinking about who the stakeholders are and sort of rattling off the same old list of stakeholders that we always talk about, but also thinking about different types of stakeholders as well. So, for example, we came across the idea of validators, who are sort of trusted people or institutions within communities that can help to communicate with communities and build trust where it might be lacking for any number of reasons. And this was the type of stakeholder which certainly I hadn't really come across much before. But you could see how that would be so valuable, especially in communities where there's a lot of distrust of health professionals or the health system, or a lack of engagement, etc. So it's something where we need to be really sort of holistic and wide ranging when we're thinking about who we define as stakeholders, and then also how we reach out to them. So not just using the same old channels, but, getting out there on, non-English language television, on social media, using influencers, whatever, but just thinking about all these different ways that we can approach our stakeholders. And then the final thing on stakeholders which emerged quite strongly from our interviews, as well as from the literature, was around how stakeholders can perpetuate disparities, both individually and collectively. So this was something that, again, we'd sort of known in the abstract can happen, etc. But knowing this and hearing this from our expert interviewees meant that we were able to build this into our analysis as well. So we identified the ways in which different stakeholders may perpetuate disparities. And then that meant that when we came to look at our actions to address disparities, we could line those up. So we could design the actions that we think people should take to directly try to mitigate the risks that they run in terms of perpetuating disparities.
That's really interesting. I took away 2 or 3 really big points from everything you were sharing. And one of those is it really sounds like there's a call for, you've provided a fair amount of insights on a call to culture change, right? And in many ways, like what is the way that we have agreed upon as the norm for addressing issues of health disparities across many areas, but in this case in particular, at the intersection of COVID, HIV, STIs, and mental health. And that seems like a bigger picture piece. And that's, I think, sometimes where it can maybe feel really intractable. But by breaking it down into these pieces, you're saying, yes, we want to achieve this bigger picture. But to do so, we have lots of small pieces each person or each stakeholder group can engage in that collectively will help us to move the needle of that culture change. That's part of what I'm hearing as a takeaway, and one driver or way or pathway in which somebody or a team of stakeholders could work towards their actions that are provided in your report is to really embrace and embed a diversity, equity, and inclusion standpoint, and take those principles and perspectives and think about how they can weave them into the design of the actions they take based on the recommendations from this report, addressing a lot of the different pieces that you raised around disparities. And then I think lastly, this last piece I thought was very interesting around saying, having stakeholders think and take the time to think and reflect, to sort of engage in critical self-reflection of where are we helping to achieve the goal that we've set out to achieve, and where are we holding it back, and to provide some insights and guidance on, or even just a call to action to begin to do that critical self-reflection. It's a really interesting combination of approaches that seems very practical for addressing a very large problem. I'm curious what your thoughts are in response to that. Does that touch on the kinds of things that you're trying to get at, or is it coming across in a way that I'm not capturing it quite right?
No, you captured it beautifully. It's exactly that. It's that we want people to think about what they can do. That's the key thing that we want people to take away from this report, is to read it and think, okay, what step can I take to help to, it's a bit of a cliche, but be the change that you want to see, and things like that. Because as you say, it's a big problem. It's not just a health problem, because, we've identified in our stakeholders that there's non-health institutions involved as well. Housing is an issue. Employment is an issue, etc. There's loads of things at play here. And so what we want to do is, as you say, break it into these sort of manageable chunks where people can look at it and say, okay, what can I do to help here? What change could we make in my organization to try to make our organization a bit more equitable, to try to positively contribute towards this more equitable future? We may not be able to change what everyone else is doing, but that doesn't mean we can't make that change, and we can't be, maybe a small cog in a much bigger system but maybe other people see what we're doing and think, hey, we could do the same, or sort of you could inspire other people. So I think that's exactly what we want people to take away from it, Kelly, is really there is something you can do about it, and here are some ideas for things that you can do.
What would you see as next steps, right? So you've provided this roadmap, you've done this work, you've investigated this really interesting and important challenge, and you've done some interesting and unique analyses. You have provided insights that are actionable. What would be next steps would you circle back to next if you had to do another partnership with VIVE as an extension of this work? What would come next?
Well, that's tricky to say, isn't it? I think really we'd just be looking for evidence of action, maybe seeing the word equity creeping into more strategy documents, but crucially, having it linked through to some kind of evaluation, some kind of measurement, some kind of accountability, because equity is a word you can insert into your strategic documents. That's easy. That's not a problem. But actually changing the ways you work to make them more equitable is something that takes a lot more work. So I think that's something that I'd really like to see is, maybe more organizations having, an equity strategy that has a sort of, an evaluation built into part of it. So saying, okay, we've got this equity strategy, perhaps it's for the next 5 years, say, that's what a lot of strategy documents run to. So what are we doing at the end of year 1? What are we doing at the end of year 2, etc., so that we actually start to see more accountability and more measurability? Because the problem is that, we can all make these sort of grand statements. We can all, say that we want to change these things and, all of these things, but actually taking action is much more difficult. And especially when we see things like, the incentives that I mentioned, if you're thinking about the way that health systems or insurance models are put together, then you see that these are quite big things that need to be implemented. And so again, it's not about changing, inserting the word equity into a strategy document. It's about looking at how your equity strategy interfaces with your policy, with your clinical practice, etc., and then thinking about that. So I think that's where, where we've highlighted those areas where stakeholders may perpetuate disparities is really important, because as you said, there's a need to be critically self-reflective about these things. I don't think many, if any of us, think, oh yes, I definitely perpetuate health disparities in the work that I do. But actually, if you were to unpick some of the practices, there may be ways in which you're directly or indirectly doing it. And that's something that's really important. And so I think the next steps are around seeing some action and linking that action to accountability mechanisms. So whether that's things like incentive structures, building evaluation into strategy documents so that we can see where progress is being made. There's lots of different approaches, but I think it's about making sure that there's that accountability and that we see evidence of action rather than just nice words, essentially.
I know that makes a lot of sense. I thank you for that. I know I've really asked you a lot of questions about the specific partnership with VIVE Healthcare, and I'm curious if there's, as we come to the end of our time together, I'm curious if there's anything else that you are particularly interested in sharing, maybe beyond this project, from your experience and exposure over the last 18 months in this pandemic and the work that you've done. Is there anything else that you would like to share with the folks who are going to see this conversation?
Yeah, definitely. I mean, I've sort of touched on it already, but, COVID didn't create health disparities. What COVID did was highlighted them, because actually something that really hadn't been, much in the headlines and things like that, suddenly you couldn't ignore some of those patterns of the way that COVID was affecting different people. the hospitalization rates, the death rates, etc. And so COVID didn't create that situation, but it helped to highlight that. And so I think that's something that's really important. And that's, again, why we didn't look just at one, particular area of healthcare, because we thought it was important to highlight what we touched upon earlier, that solutions aimed at specific diseases are really important, but they can't achieve that systemic change that's needed. So that's, again, why we think about things like incentives within health systems, because that is how you get change to happen, is by looking at the health system structures, not just sort of looking at an individual program within a particular disease area. And I think also, sort of, again, taking that slightly zoomed out view, something that I haven't mentioned yet is that our research focused in on the United Kingdom and United States. So those are two completely different healthcare systems. But the reason why we chose them was because despite them being very, very different, we saw similar patterns of disparities and their impact. So, some of the figures we've got in the report, you can see that actually they're having a very similar impact, and they're following very, very similar lines, despite being so different. So that points to us, seeing something pretty fundamental about the way that health disparities operate. And that goes beyond individual diseases. And it really goes to the heart of, how health systems are organized. And, as I said, things like incentives. But it also shows that while this research, we've looked at the UK and US as our focus, it's also applicable to, many other countries beyond those two. And also when we're sort of thinking about the stakeholders, we called it a stakeholder ecosystem, because we wanted to emphasize that everyone has a role to play in reducing disparities. So it's not the job of one sector or one organization or one individual, because exactly as we've discussed, the causes and effects of disparities are so cross-cutting that isolated intervention is only going to have an isolated impact. And in creating this ecosystem, we wanted to show how these stakeholders can coordinate in a shared vision of health equity. And then a final point that I'd like to make on health disparities in general is that health disparities are something that affect most people. There are very few people for whom they do not impact in some way, shape or form, even if indirectly. They affect huge numbers of people in our societies. In the UK and US alone, we're talking about millions of people. And they also have huge social and economic impacts on an individual and societal level. So it's something where it really is incumbent on us all to take the action that we can to address disparities. Because one of the things that I found very impactful was, I think it was the WHO defined health disparities as being avoidable and unfair. And also one of the things that we highlight in our research is the way that they cost us all. So it's something that we all need to take action on, and we all need to collectively get behind in order to get some action and some resolution here.
Yeah, thank you. I appreciate that. And we're getting ready to close, but before we do, could you possibly give us some guidance on where to find the findings of your work when it is published? I'd love to know where to go to look to pull it and read all the detail that your team has put together.
Great question. So it'll be published on the Economist Perspectives website. So that is eiuperspectives.economist.com. And there'll be a special sort of landing page where you can find that. And there's going to be a report, so a report sort of highlighting all the key parts of our research. And also we've got some sort of meaty appendices in there for anyone who really wants to get into, the research and how we did it, as well as sort of, a nice executive summary for anyone who just wants to sort of dip the toe in the water. We've also got a couple of videos coming out which will highlight some key aspects of the research and case studies as well. So again, just really thinking about how we can make all of this really actionable and giving people lots of different ways to access our research.
Oh, that's great. And it just sounds like there's a lot of different resources and ways to consume the information, that it can all be found on the website that you provided. When it's published in just a few more weeks, a few more short weeks.
Just a few weeks, yeah.
More short weeks. Well, Elly, I thank you for your time today. I really appreciated having the conversation and learning about the work that you've been doing in this space. And